So today we have for our Research to Practice lecture, Radiation Oncology in North Carolina, Bladder Cancer Updates for 2020 with Trevor Royce, MD, MPH. Dr. Trevor Royce is a clinically active radiation oncologist specializing in genitourinary malignancies. He is an engineer by training with a BS in biomedical engineering and an MS in physiology and biophysics. His formal research training included a Doris Duke Clinical Research Fellowship at the University of North Carolina and a Master's in Public Health from the Harvard School of Public Health, both focused on health services research. He also served as Health Policy Fellow for the American Society of Clinical Oncology. He has a particular interest in the value and financial aspects of care and efficiency of care delivery, as well as comparative and cost-effective analysis. The overreaching goal of his research and national committee involvement is to impact clinical practice and health policy. He has published on cancer care utilization and patterns of practice, focusing on identifying areas of healthcare inefficiency. Dr. Royce, welcome. If you want to go ahead and unmute your audio and video, there you are. Hey, good to see you today.
Nice to see you. Thanks for having me.
Absolutely. So what's something that I left out? What's something maybe we can know about your personal interests aside from your very impressive professional bio there?
I guess one thing that's nice to share is I'm a North Carolina native, and it's a real pleasure to be caring for the people of our state. I grew up in Raleigh, and my wife is an emergency physician here in the UNC network as well. So we're very happy to be here with this great community.
Very good. Very glad that it's a family affair. That's great. So let's take a look at our first polling question. Which of the following is not typically considered a potential system for bladder cancer? A, blood in the urine, B, painful urination, C, pelvic pain, or D, memory loss. And Dr. Royce, we do try to make these kind of softball questions, so I think our audience will get this. While we're waiting for them to go ahead and take care of that, this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Continuing Professional Development, the UNC CPD. William A. Wood, MD, MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Trevor Royce, MD, MPH, has no financial relationships with commercial interests as defined by the ACCME. And let's take a look at that poll. I'm seeing a pretty strong trend here. How are they doing, Dr. Royce?
Doing pretty good.
Good.
I'm not sure we need the talk now.
Uh-oh. No, I think we still need it. They did well, but let's go ahead and do the talk. So, and of course the answer was memory loss is not typically considered a potential symptom for bladder cancer. So without further ado, radiation oncology in North Carolina, bladder cancer updates for 2020. Dr. Royce, take it away.
Thank you very much, Tim, for having me, and thanks to you and John and everyone for all the effort and time you put into setting this up. It really is an impressive production to have this go across the UNC network and now virtually. I've been very impressed with the energy that went into this, so I appreciate that. Today we'll be talking about bladder cancer, particularly the multidisciplinary management of bladder cancer. And I thought it would be valuable to cover this topic and give the radiation oncologist perspective, because it definitely is an area that has the management of has changed over the years, and it's a cancer that is common, but sometimes flies a little bit under the radar. So I'm glad to be here and speaking with everyone today, and we'll be highlighting the multidisciplinary management of bladder cancer. Next slide, please. Have no disclosures. So our objectives today will be to describe the role that radiation can play in the management of bladder cancer. We'll also compare the roles of radiation in surgery and the treatment of muscle-invasive bladder cancer, and particularly we'll spend a lot of time talking about muscle-invasive bladder cancer management. We'll also recognize the toxicities and the quality of life implications of radiation therapy for bladder cancer and some of the trade-offs involved thereof. Next slide. So just to get everyone engaged, we've got a few poll everywhere questions, and we can start off with this one. Which of the following cancers will be responsible for the most deaths in the year 2020? Melanoma, uterine endometrial cancers, kidney or renal cancers, or bladder cancer.
And as always, these are anonymous, so feel free to take your chances with these. I think that's probably enough time. Dr. Royce, how are they doing?
They're doing pretty good. I think we can go to the next slide and review. Great. So, there was a little bit of variability there, and I like this question because, as I mentioned, bladder cancer sometimes kind of goes underreported. It is often less publicized, or there's fewer research dollars behind bladder cancer compared to some of these other cancers. And I think it's important to highlight where it sits in the context of cancers. And in fact, out of these cancers listed, bladder cancer would be considered the most deadly by the number of deaths. It's almost 18,000 for the year 2020. You do next slide. So just by way of background, and this is a very high-level overview here, obviously, of the anatomy and of bladder and where it sits in the urinary system. I like this picture because it does show where the bladder is anatomically and how one can imagine that might be a hard-to-reach area of the body when we're thinking about treatment, either surgically or with radiation, and also what might be nearby. And we'll talk a little bit more about that. We can go to the next slide. So here highlights the epidemiology and where bladder cancer sits in relation to some other common types of cancer. It relates to the question we just went through. And there will be about 80,000 new cases of bladder cancer this year alone, and that can account for almost 18,000 deaths. Again, that's more deaths than non-Hodgkin's lymphoma, kidney, renal cancers, uterine cancers. So it is a common cancer, and we'll talk a little bit more about how these patients present on the next slide. The major risk factor for bladder cancer is smoking, and the vast majority of our patients with bladder cancer will have a smoking history, and that is certainly relevant for our patient population here in North Carolina. I've also highlighted a couple other risk factors for bladder cancer. Certain chemicals, exposure thereof can cause it, as well as some chronic irritative conditions like chronic bladder stones, or we see it perhaps more commonly with the setting of a chronic indwelling Foley catheter, and that irritation and inflammation over time can ultimately lead to a bladder cancer. This last bullet there under chronic irritation, schistosomiasis, is a parasite, and it's interesting, just as a sort of factoid or tidbit, that can be associated with a specific type of bladder cancer or squamous cell carcinoma. And so in areas where they have high levels of this parasite infection, schistosomiasis, a good example is in the country of Egypt, where it can be in some of the freshwater rivers and lakes there. They have higher rates of squamous cell bladder cancer caused by the schistosomiasis, and it can be treated and respond a little differently from the types of bladder cancer we see here in the United States, which are more often related to smoking and less commonly some of these chemical exposures. Next slide, please. So we mentioned that in terms of presentation, by far and away, the most common presentation is blood in the urine, and that can be either grossly visual or microscopic, and indeed 75% of cases will have blood in the urine when they present for bladder cancer. Other less common symptoms can be these things like irritation with voiding, pelvic pain, or obstructive symptoms. Bladder cancers can often be multifocal in nature, and we'll certainly talk a little bit more about that. It's important also to acknowledge that there is quite a spectrum in bladder cancer in regards to how invasive it is, how advanced it is. The majority of bladder cancers are non-muscle invasive, meaning they're superficial bladder cancers, 70 to 75%. However, 20 to 25% are muscle invasive, and this is a very serious diagnosis and can require quite aggressive treatment. And around 5% of patients will present with metastatic disease. We can go to the next slide. So this is that in a little more detail, reviewing the staging of bladder cancer. And again, staging is simply a way to characterize how advanced that cancer is. Again, the great majority of bladder cancer patients at presentation will be non-muscle invasive or stage 0 or 1 bladder cancer. And this cartoon or schema in front of us is just showing the different levels of invasion by T stage or tumor stage for bladder cancer. So T1 there is just invading beyond the surface of the bladder cancer, but not yet into that muscle body of the bladder. And that would be considered a non-muscle invasive bladder cancer. Stage 2 or 3 bladder cancers are considered muscle invasive bladder cancer. And this will be the group that will be the primary focus of today's talk. This is a very serious diagnosis, and we do need aggressive therapy for that. And this is when the bladder cancer, again, has grown to the point where it's invading into that muscular wall of the bladder itself. And we can go to the next slide. So one classic treatment for muscle invasive bladder cancer, long considered the gold standard, is the radical cystectomy, or the surgical removal of the bladder. And I wanted to show this slide. We're not going to be, I'm a radiation oncologist. We'll spend most of the talk talking about how radiation plays a role. But it's important to acknowledge the anatomy and what's nearby and what is involved when we surgically remove a bladder or do the radical cystectomy. And then on the top panel here, it shows the structures encompassed in the dashed line that traditionally would be removed for a man getting a radical cystectomy. That includes the prostate sitting just below the bladder itself, obviously, the seminal vesicles, and the proximal part of the urethra there. And the bottom panel here is showing, again with the dashed line, the anatomical structures that are typically removed for a radical cystectomy in a female. It's important to acknowledge that this includes much more than just the bladder itself. This would include also the uterus, the ovaries, and sometimes the anterior vaginal wall there and the proximal urethra. Again, this, as we saw in that first slide of anatomy, this is deep in the pelvis. So this is a major procedure in a very tight area of the body, and it requires, a certain and great amount of surgical expertise and experience to do it successfully. Often, before radical cystectomy, to treat muscle invasive bladder cancer, we give chemotherapy beforehand. We call that neoadjuvant chemotherapy. We'll see that abbreviated NAC in the talk. Next slide, please. So when we remove the bladder, which serves anatomically or physiologically as a reservoir for urine, we have to have some path for that urine to go, some way for us to excrete those toxins in urine and have a functional urinary tract. And again, I'm not a surgeon, I'm not going to go into too much detail with this, but there are different approaches to permitting a functional urinary tract without a bladder being present. And broadly speaking, we can put this into the groups of incontinent diversion, meaning you have basically an ostomy or a urostomy or a bag that collects urine. So instead of, that's effectively acting as a bladder but outside the body. It's called incontinent because you don't have control over when that urine enters and exits the body. That bag just fills up gradually over time. Alternatively, there are strategies to maintain continence or control over when the individual releases their urine. And there are a couple different strategies for that. I've highlighted here where you can use part of the gut and create a reservoir or a bladder artificially, and you can catheterize that. Next slide, please. All this is to say that, clearly this is a major procedure, and it has very real quality of life implications for our patients. I show this because this is a picture of an ostomy, and you can see the scar on the patient who's had the radical cystectomy, and we should acknowledge that there are quality of life implications to any treatment that we do for cancer, and certainly in bladder cancer, as we consider things like a urostomy, a permanent ostomy bag for that patient. Next slide, please. So we'll frame this talk today and consider if there are other treatment options for bladder cancer beyond the traditionally considered radical cystectomy. And I would challenge you all to consider for a second, are there ways for our patients to actually keep their bladder even in the setting of an advanced bladder cancer diagnosis or a muscle invasive bladder cancer? And of course the answer to that is yes, there are strategies where patients can keep their bladder through the use of what we call trimodality therapy. And we'll talk about that in great detail. Next slide, please. So, which are treatment options for muscle-invasive bladder cancer? The radical cystectomy or trimodality therapy. And this is just to hit home this important concept, which is one of the major takeaways from the talk today. And I'm very excited to see these responses coming. If you take nothing else away from the talk today, take away that trimodality therapy, or being able to preserve your bladder, is considered a reasonable treatment option for patients with muscle-invasive bladder cancer. And we'll talk about the selection and the appropriateness of it in different patient populations for much of the remaining talk. Okay, great. We can go to the next slide. Very good. So that's correct, all of the above. And we'll talk about the nuances behind that decision making. Next slide. So this is a famous surgeon. He passed away just within the last year, actually at the age of 100. And this is Bernard Fisher, who was based for much of his career at the University of Pittsburgh. And I wanted to highlight him in the setting of this talk for a couple reasons. He is famous for championing and studying and pioneering breast conservation therapy for breast cancer. So traditionally, women would have a breast cancer diagnosis, and many of them would have their breast completely removed. And he challenged that dogma and thought, well, maybe we don't actually have to have such a large procedure with its morbidity and psychological impacts, and maybe we could have equivalent outcomes while preserving the breast. And he achieved this dogma challenge, if you would, through rigorous study and importantly through randomized controlled trials, so that we had good evidence that showed that it was acceptable to engage in breast conservation therapy, and that in fact it was okay with a data-driven approach that not all women had to have a mastectomy. And I would take that a step further. Instead of just thinking about it as breast conservation therapy, but think about how that might apply to other cancers beyond breast cancer, in which case we could maybe just call it organ preservation more broadly. And we can go to the next slide to talk about that some more. So I'm making the argument today that organ preservation is really a hallmark of modern cancer care. And ideally this is established through good data in the form of randomized controlled trials, which would be considered the gold standard of evidence-based decision making. I've highlighted a couple of disease sites where this concept of organ preservation, or being able to keep the tissue in question, in a couple of different cancer sites. We just talked about breast cancer, how there's been this huge shift in the paradigm from everyone getting a mastectomy to being more selective about who needs a mastectomy and who can qualify for breast conservation therapy. That same concept applies to larynx cancer, where we would more traditionally do laryngectomies, or complete removal of the larynx and the voice box, in a shift towards larynx preservation, allowing patients to actually keep their native larynx. Sarcomas, it's the same. And before the 80s, we used to just remove the limb, complete amputation for sarcomas. And then in the setting of randomized trials, this is true for larynx, we found that limb-sparing approaches for sarcomas were acceptable, and that with surgery followed by radiation, we could have the same effect and better functional outcome than complete removal of the limb. And so the general principles across organ preservation for all of these cancers include the following. Number one, perhaps most importantly, is that it requires the expertise of a multidisciplinary team, and that it really is teamwork amongst specialty teams, all contributing their unique knowledge and treatment modalities to achieve this goal of maximal organ preservation without sacrificing cancer outcomes. More broadly, the general approach is surgery can really be used for maximal cytoreduction, or removal of the large bulk of the cancerous tissue. However, that surgery may leave some cells behind because we have not removed the entire organ. And for those microscopic residual disease left behind, or perhaps cells that have gone to other parts of the body distantly, that's where systemic therapy like chemotherapy or more targeted therapies can come into play, and certainly radiation can come into play as well. And the ultimate goal would be to maintain the function and preserve the quality of life of our patients without compromising disease control or risking the chance at treating the cancer. Next slide, please. So we'll apply this sort of framework to bladder cancer. Is there a role for organ preservation in bladder cancer? What is the role of radiation? What is the impact on disease control? And what is the impact on quality of life for our patients? Next slide, please. We don't have to go into this level of detail, but just very briefly, some background on radiation and how it works and sort of what it is. So radiation works by damaging DNA in a manner that prevents effective cellular division. Another way to think about that is, well, tumors are simply cells that are growing uncontrollably, and radiation can prevent that growth by damaging the DNA of those tumor cells. A common strategy with radiation is that we give radiation over many doses. So we give a little bit of radiation every day for many days. This allows our normal tissue to repair its DNA. Our normal tissues have their DNA damaged just as tumor cells have their DNA damaged by radiation. However, tumor cells struggle with repairing that DNA damage. While normal tissues are much more functional at repairing their damaged DNA, and we take advantage of this difference amongst tumor cells, which struggle with repairing their DNA, and our normal tissue cells, which are more capable at repairing their DNA. And we can therefore treat the cancer while sparing our normal tissues with radiation. And we can give drugs as well that can help sensitize or enhance this process, radiosensitizers. Next slide, please. So let's talk about the multidisciplinary nature, interdependency of organ preservation, again in the context of bladder cancer. Next slide, please. This is probably one of my favorite slides from the talk because this shows the general treatment paradigm for how we can preserve the bladder but still effectively treat a muscle-invasive bladder cancer. And this is through what we call TMT, or trimodality therapy. The tri stands for the three modalities used for this. One being radiation, two being surgery, and three being drugs or chemotherapy. So that's the tri-modality therapy, and we can incorporate these to preserve the bladder. The general process for patients is the following. First, they have a maximal transurethral resection of the bladder tumor, or TURBT. This is when the surgeon or the urologist, urologic oncologist, goes into the bladder and removes as much of the tumor as is possible. Again, this is taking advantage of that maximal cytoreductive capability of a surgeon. They go in and remove the great majority of the tumor. After that's been done, they still have their bladder, and we deliver radiation with chemotherapy. Again, the chemotherapy can help sensitize those tumor cells to radiation. This involves daily radiation treatments for many weeks, usually around 6 weeks or so. So now the patient has had their TURBT, the surgeon went in and removed the bladder tumor, then they received their chemotherapy with radiation, and then we look inside the bladder to see how the tumor has responded, and that's the cystoscopy for treatment response. If there has been a complete response and we see no evidence of tumor, then that's great, and we can just watch the patient very carefully. Again, this watching the patient would happen, say, every 3 months with a cystoscopy, much like we get CT scans for surveillance for other types of cancers. In bladder cancer, we would get that as well as looking into the bladder and being sure that the tumor has been eradicated. If those surveillance cystoscopies demonstrate the tumor is returned, we would call that a recurrence, in which case at that point they would go on with a cystectomy where we would remove the entire bladder. So the yellow circles with the U represent areas on this treatment paradigm where the role of the surgeon or the urologic oncologist or the urologist is absolutely essential to the successful execution of this treatment paradigm. And then in the blue circle is where the radiation oncologist and the medical oncologist are essential in this treatment paradigm. And I hope, if you take nothing else away from this talk today, that this very nicely shows how critical having a multidisciplinary approach to bladder cancer can be in the successful treatment of muscle-invasive bladder cancer and allowing our patients to keep their bladder. Next slide, please. So I think we've shown in that last slide, and I chose this quote from one of my mentors in Boston, that trimodality therapy starts and ends with the urologist. The urologist is critical in this treatment paradigm. It involves the maximal TURBT, where the tumor is removed. If chemoradiation is unsuccessful, then the urologist can salvage that patient by removing the bladder with radical cystectomy at that time. And of course, there's lifelong cystoscopic surveillance where we check and make sure all is well in the bladder and the patient can continue to keep their native bladder. Next slide, please. So we have described the concept of trimodality therapy. We've described how it's done, how we use the unique skill sets of the surgeon, of the medical oncologist, and of the radiation oncologist to achieve this. But none of that matters if the outcomes are not satisfactory. And so let's take a little bit of a dive into the literature. We'll try not to get too far into the weeds about what the outcomes for trimodality therapy are. Next slide, please. So the history of trimodality therapy for muscle-invasive bladder cancer. This is a good example of rigorous and systematic investigation over decades to get to the point where we feel comfortable doing this. And this is really the advancement of modern cancer care in front of our eyes, so to speak. Protocols started investigating using trimodality therapy or surgery and radiation and chemotherapy to treat bladder cancer in the 80s. And we don't have to go through each decade, but suffice to say that we have tweaked with the ordering and drugs and general approach for these different therapies over time. And I would argue that the long-term results of trimodality therapy using radiation and chemotherapy to treat bladder cancer are comparatively excellent in appropriately selected patients compared to radical cystectomy alone. Next slide, please. And this is just showing that. So this is a nice study that was in the Journal of Clinical Oncology in 2014, which pooled a lot of the results from these cooperative group trials that studied these trimodality therapy approaches for muscle-invasive bladder cancer. On the left here, we have survival over time, and you can see by around 5 years, if you made it that far, you're essentially cured of your bladder cancer. And these are patients with muscle-invasive bladder cancer, and they're surviving around 60% or so. The middle graph here shows two curves split by T stage, so T2 or more advanced T3 or T4 cancer. And on the right, that pair of curves shows those that had a complete response to chemotherapy and radiation versus an incomplete response. And I think the important takeaway from those is that clearly some patients do better with trimodality therapy than others. Clearly, if you have a T2 tumor, you're going to do better with trimodality therapy, and if you have a complete response, meaning there's no evidence of tumor after you've had chemotherapy and radiation, you will do better. And what I'm getting at with this nuance is that there are patients that are the optimal candidates for this approach of using chemotherapy and radiation, and there are patients that are probably not the best choice for a trimodality therapy approach for their muscle-invasive bladder cancer. And it's important for us to understand who might be a good candidate for it versus who might not be a good candidate for it. Next slide, please. So as we've shown earlier, trimodality therapy really relies on multidisciplinary care. I think it's an excellent model for how multidisciplinary cancer care really can push forward the outcomes of our patients. This is showing what the outcomes are like if the patient has a good, complete transurethral resection of the bladder tumor by the surgeon before they go on to get chemotherapy and radiation. And men that have, or patients that have a complete transurethral resection, the red curve, do better over time than those that have an incomplete one. So the more that the surgeon can get out and have a maximal debulking of that tumor, the better the outcomes. This speaks in part why it's good to go to someone that has good experience and is comfortable with doing these types of procedures. An important question to ask is, how often are patients that get chemotherapy and radiation or trimodality therapy for their bladder cancer, how often do they ultimately get to keep their bladder? Remember, if that tumor comes back, the surgeon will go in and remove that bladder with a radical cystectomy anyways. Well, you have at least a roughly 70% chance of actually keeping your native bladder despite your diagnosis of a muscle-invasive bladder cancer with this approach. And so many of our patients really, truly do get to keep their bladder long-term in the setting of this diagnosis. Next slide, please. Again, this is very much a multidisciplinary endeavor, and the radiation really relies on good chemotherapy to be as successful as it can. And this was proven in a randomized trial out of England called the BC2001 trial, where they randomized patients to either radiation or radiation with chemotherapy for their muscle-invasive bladder cancer. And you can clearly see from the curves below that the blue line, chemo with radiation, is doing better than radiation alone. So now in the last two slides, we've shown, number one, how important it is to have a good surgeon to go in and remove as much tumor as possible. And number two, to have good chemotherapy to really prime that tumor for the effects of radiation. Next slide, please. It's important to acknowledge also that we've gotten a lot better at this over the decades. And this is because we've improved, number one, the patients that we select for trimodality therapy. We've also improved their techniques from the urologic standpoint, certainly the radiation standpoint, and also from the medical oncology standpoint. And all of these advances have ultimately resulted in us with better outcomes for our bladder cancer patients. And all three of these are just showing basically improved rates over time from earlier decades to later decades. Next slide, please. A critical concept for trimodality therapy, or a bladder-sparing approach for someone with a muscle-invasive bladder cancer, is selecting the appropriate patient. And we've talked a lot about this already. You know, patients that have smaller tumors, T2 versus a T3 do better. Patients that have had good TURBT or maximal debulking of the tumor do better. Other things to consider are things like age. You know, older patients may not do as well with surgery because of functional status or other limitations. Along the same lines, there may be certain comorbidities that make them not a good surgical candidate. So these are things to consider. It's also critical to consider how the function of their bladder, of their native bladder. If their bladder doesn't work well at baseline, then maybe it's not a bladder that's worth saving. And again, that's the whole goal and rationale behind this, is to try to save the bladder. We talked about the tumor factors, including the T stage. Another important one is the presence of something called CIS, or carcinoma in situ, which may suggest that the bladder is more diffusely involved. Another one is hydronephrosis, again, probably a surrogate for the extent of the tumor involvement. Next slide, please. So we've covered a lot of these, but which of the following are relative contraindications for this approach, trimodality therapy or chemoradiation for bladder cancer? Maybe younger patients could get more surgery or do better with surgery, same with fewer comorbidities. We talked about poor bladder function being important to, having a good bladder function is important for preserving the bladder. Larger tumors, carcinoma in situ, hydronephrosis, or incomplete transurethral resection of the bladder tumor. And the final answer there is H. All of these above would be relative contraindications for trimodality therapy. Terrific. Correct. So all of the above relative contraindications for trimodality therapy. Next slide, please. So when we first introduced this concept of organ preservation in modern cancer care, we said that ideally it's established through randomized controlled trials. Without, we want to show that we can keep the bladder, have a good quality of life, but we don't want to sacrifice disease control. Next slide. So we should ask ourselves, well, how does radical cystectomy or removal of the bladder compare to this new approach of trimodality therapy or bladder sparing? Next slide. Well, we have tried to do this, or investigators have. This is a trial out of the UK, England, where essentially investigators flipped a coin, and heads you got your bladder removed, and tails, you got to keep your bladder, and you had chemotherapy and radiation. As one might expect, this is a very challenging trial to execute. It's very hard for patients and investigators as well to come to terms that we're going to leave the surgical option up to chance. Flip a coin and you get your bladder removed or not. You know, people have strong opinions about this, and a lot of patients don't want that major decision to be left to chance. Unfortunately, this trial closed because it could not get enough patients enrolled. Next slide, please. So if we don't have randomized controlled trials, we have to look towards other types of data. Again, we don't have to get into the weeds of all this. It gets a little technical, but there are different approaches to studying cancer outcomes beyond the randomized clinical trial. These are considered lower levels of evidence. One example, or a couple examples that I've shown here, is you can go and look at billing claims and see how patients have done based on what their billing records show and try to make, an inference from that. And there are plenty of limitations to that I'm happy to talk about later. You can also look at patient-level studies, so maybe an institutional experience. Our center has treated a lot of patients with trimodality therapy. How have they done over time in characterizing that? These can be difficult to apply to other environments outside that specialized center. Next slide, please. At any rate, I think the important takeaway is that a lot of studies have been done to try to compare radical cystectomy to trimodality therapy. They all have their limitations, and I've just summarized a couple of the more recent studies here in this chart. So in this chart, each row represents a different study that tried to compare trimodality therapy to radical cystectomy, and then that last column on the far right shows their outcomes in terms of overall survival. And I think the takeaway from this slide is that the results really are mixed, and it depends on how the study was done and what kind of biases were introduced. The first three all showed that radical cystectomy did better, but in the bottom three, it showed that there was no difference between surgery and trimodality therapy. Next slide, please. So what do we do when randomized controlled trials fail us? Well, we have these retrospective studies that have tried to compare things, but they are very limited. And part of that is how these treatment decisions are determined in the retrospective fashion. As we've mentioned, trimodality patients, or patients that get radiation and surgery, are often older patients, and they often have worse performance status. They weren't candidates for surgery to begin with. And so you can imagine that they might have worse outcomes, and that sort of stacks the cards against the radiation and chemotherapy approach. It's also hard to compare apples to apples because when we've removed the bladder, we have a much better idea of what stage they were. Whereas with radiation and chemotherapy, we're relying on CT scans and their limitations to decide, how advanced that tumor is. And oftentimes these database studies are what they actually received is unclear because it really is a look back in time. We may or may not know what they ended up getting. I highlighted in the bottom right here one of the curves from one of the more robust studies that was out in the Journal of Clinical Oncology comparing radical cystectomy to trimodality therapy in a multidisciplinary setting at a single Canadian institution with a lot of experience at this. And as you can see, the outcomes are very similar and essentially the same. Next slide, please. If it's thought that the outcomes in appropriately selected patients are roughly the same between radical cystectomy and trimodality therapy, again, we have to ask, well, what about quality of life? I mean, that was the whole point of going down this road of having patients being able to preserve the bladder. Does it really matter? Do they have good function of their bladder after chemotherapy and radiation? And are they happy with that? And does that make them live better lives? Next slide, please. And people have been trying to investigate this. Admittedly, it's still early as far as these things go, but it is an area of rapidly developing research. We're investigating what the quality of life is of our patients that keep their bladder with muscle-invasive bladder cancer diagnosis. I'd highlight a couple. The first is the Massachusetts General Hospital Quality of Life Study, where they had 221 patients treated with trimodality therapy over 3 decades. They followed them for 6.3 years. They did all sorts of tests to see how their quality of life was. They found 80% of patients that got chemotherapy and radiation had a compliant bladder with good capacity and flow, meaning a functional bladder. Next slide, please. This is a very nice study that was a collaboration with investigators here at the University of North Carolina in Massachusetts General Hospital, Harvard, and Boston. And you'll see a lot of our clinicians here at UNC listed, including Dr. Smith and Dr. Malowski, Dr. Chen, Dr. Nielsen, amongst many others. Next slide, please. They had 206 patients with radical cystectomies and patients with trimodality therapy, and they tried to compare the quality of life between these two groups. And they found that trimodality therapy was often associated with higher general quality of life, higher bowel function, higher sexual function, which makes sense when you think about all the structures that are removed with a radical cystectomy. I'd say that these studies all have their limitations, and this needs to be investigated in a more rigorous fashion before we can make any definitive claims about the quality of life benefits with trimodality therapy. But certainly, at the minimum, these are hypotheses generating in favor of considering trimodality therapy for certain patients that want to keep their bladder. Next slide, please. So again, you can do modeling studies to try to measure what quality of life improvement might be gained with trimodality therapy. These modeling studies have their limitations. This is one that I did where we essentially simulated how patients did over time, going down the radical cystectomy path or going down the trimodality path, and kind of what the ultimate quality of life outcomes are, and trying to measure or quantify what quality of life might be gained with trimodality therapy. If you go to the next slide, please. This is sort of the main takeaway. This incremental value is showing the quality of life years that could be gained with trimodality therapy. And our study did find that there was the potential for improved quality of life with trimodality therapy with equivalent outcomes in terms of cancer control between the two groups. And again, an essential part of trimodality therapy is the ability to still salvage the patients later if they fail with a radical cystectomy or removal of the bladder. Next slide, please. And I would just like to highlight another quote from another one of my mentors in Boston, Anthony Zeitman: "The best bladder you will ever have is the one you were born with." And, you know, it makes sense that if our goal is to maximize quality of life and patients have a good functional bladder, it's unlikely that we'll be able to replace that bladder function with something artificial. Next slide, please. So as I mentioned, this is an area ripe for investigation, and plenty of that is going on here at UNC. And in fact, investigators have created a symptom scale to more specifically measure the quality of life of bladder patients as they go through these treatments. Next slide, please. And I guess just as we wrap up, I would challenge us to sort of rethink how we approach these patients and reframe the discussion a little bit. The question or the discussion is not to consider radical cystectomy or removal of the bladder versus trimodality therapy, but really these should be thought of being on a treatment spectrum and identifying which treatment approach might be better for a select patient. These are really complementary tools in our toolbox for the treatment of bladder cancer. One is not better than the other. It's that one might be preferred for certain patients over the other. I think we showed that long-term results of trimodality therapy are comparatively excellent in appropriately selected patients. This sort of highlights how we are thoughtful about how we select patients. This is from a database study just showing on the x-axis different age groups getting older as you go farther down the right, and that the number or the amount of patients getting surgery declines as we get older patients because surgery may not be the best choice for them. Next slide, please. And so this is sort of a nice mental framework that illustrates visually what we just discussed. The x-axis is trimodality therapy going towards the right. Maybe that would favor patients choosing trimodality therapy. The y-axis is radical cystectomy. Maybe going upwards on the screen would be going towards patients where radical cystectomy would be the best option. Just to take a couple specific examples, you know, a patient in the top left here with very poor bladder function would be a better radical cystectomy candidate, because if they have a poor bladder function, there really is not much reason to consider a treatment that would keep their bladder. In the bottom right, to take that on the extreme setting, you may have a patient that feels very strongly with a desire to keep their bladder, and they may be a very high surgical risk, in which clearly trimodality therapy may be the preferred approach for that specific patient. And so this is really how we should think about this on a spectrum. There may be patients where radical cystectomy or surgical removal is the right choice versus trimodality therapy, where they get to keep their bladder. Next slide, please. And I guess I would just sort of end the talk by highlighting that just in the year 2019, radical cystectomy, long considered the gold standard and a Category 1 recommendation for the treatment of muscle-invasive bladder cancer with the NCCN guidelines, sits alongside trimodality therapy or concurrent chemoradiation, also as a Category 1 treatment option for patients with muscle-invasive bladder cancer. And this is the first time, after 30 years of studying this, where we have successfully been able to put concurrent chemoradiation or trimodality therapy alongside radical cystectomy. And this is, again, showing a major shift in the treatment paradigm where this concept of bladder preservation or organ preservation in modern cancer care has become mainstream or considered appropriate. Next slide, please. So just to hit home that point, which are NCCN Category 1 recommendations for the treatment of muscle-invasive bladder cancer? A, radical cystectomy or surgical removal. B, trimodality therapy or chemoradiation. Or C, all of the above, both being reasonable choices for a patient with a muscle-invasive bladder cancer. Again, under the caveat of their patient characteristics and preferences. Great, so we can go to the next slide and we'll finish up. So it's essential that these patients are informed of all their treatment options by being evaluated in a multidisciplinary clinic with a team of urology, medical oncology, and radiation oncology. And ethically, I would really challenge us to consider if it's appropriate for these patients not to have this discussion, because they really should know what their treatment choices are. And they should know that if they want their bladder removed, that's an excellent and reasonable option. And if they want to keep their bladder and maintain their native bladder, that also is a reasonable treatment option in certain settings. Next up, the slide, please. I've got a couple slides here at the end. I don't think we're going to go over these, but they just show sort of generally future directions of the field. We're looking at doing radiation after they've had their bladder removed. Next slide, please. And also looking at the role of radiation in the non-muscle invasive bladder setting. Next slide, please. And there are many trials also looking at the use of immunotherapy in this trimodality therapy approach and how we might be able to maximize the effectiveness of chemo and radiation by the adjuvant immunotherapy. Next slide, please. And this is a trial that we have doing just that, open here at UNC, where patients can get radiation and chemotherapy, but also get a targeted immunotherapy agent to maximize their chances of success with this trimodality therapy approach. And this is a very exciting area of bladder cancer research. Next slide, please. This slide gets a little bit into the weeds and is a little bit too far afield for us, so we can go to the next slide, please. These are references, and I'd encourage everyone to reach out with me if you have any questions or want to talk about any of this stuff further. Next slide, please. And I'd like to thank my mentors from training and elsewhere here at UNC and in Boston, and then our wonderful UNC Urologic Oncology team. Too many people to name, but the major categories listed here. Next slide, please. We can take a few moments of questions.
All right, Dr. Royce, thank you so much. That was extremely informative. We will, as Dr. Royce mentioned, this is open for questions now. So all you need to do is use the poll everywhere that you've already logged into, and you could submit questions. Looks like we may have one already in. Let's see. Here we go. And that should pop up on the screen. Since previous pelvic radiation is a risk factor for bladder cancer, could one receive pelvic radiation again for bladder cancer?
Great question. Briefly, the answer to this is sort of nuanced and really depends on what the setting of their prior pelvic radiation was for, and also how much time has passed from when they got their radiation the first time to when they might get their radiation the second time. It also depends on how much and how the radiation was given. So it really is a case-by-case basis, but I think the important takeaway is that just because you had radiation before does not mean that you cannot get radiation again.
Good to know. Thank you. And what I'll do is I'm going to leave those questions open and come back to those. I'll do a couple of other things we need to do before we close out the today's webinar. So let me go to that, and then I'll come back and see. Let me just double check. Nothing has come in yet. So keep feeling free to submit questions. While you're thinking about those questions for Dr. Royce, I will say a big thank you to the University Cancer Research Fund, funded by the North Carolina General Assembly. So thank you for that. Thank you to the UNC Lineberger Comprehensive Cancer Center. And we want to especially thank Mary King, Veneranda Obore, and John Powell for all the hard work that they do for each and every one of these lectures. I'll also say that you can find us at UNCCN, at unc.edu, 919-445-1000. And we have a lot of information on the web, unccn.org. Now I'll go back, and I do see that we've got some more questions that have come in. Thank you so much for those. So let's see. All right, so the next one, how is completeness of TURBT resection best determined?
Good question. Usually that is a determination by the treating urologist, and they'll have a general sense of whether they were truly able to get down to the base of the tumor and scrape out the bulk of the tumor. And often what that will mean practically is they'll scrape the tumor, and then they'll be able to get down to the muscle layer that sits beyond the tumor. And that would help inform the completeness of the TURBT.
Great. Thank you so much. And let me see, we've got a few more here. Since we in pathology cannot evaluate the margins of a TURBT specimen, how is completeness of TURBT resection determined to help predict response to trimodality therapy?
So similar to the prior question, it really is a subjective urologic oncologist determination on whether they felt they were able to really get to the base of the tumor, visualize the muscle layer, and visualize getting rid of the gross tumor. The purpose of the TURBT is really to remove the gross and bulky tumor so that the chemotherapy and radiation can take care of whatever microscopic disease might be left behind. So it doesn't necessarily have to be negative margins. It's complete by a subjective urologic assessment.
Thank you, Dr. Royce. And another one, how does the presence of concurrent prostate cancer, Gleason 4+3, affect treatment for bladder cancer? How common is it for the two cancers to be present in a single individual?
Oh boy, that's a very good question, and it really is quite common. And part of that is just because prostate cancer is so common. Many of these patients are older patients with bladder cancer, and if they're a male, they have a very good risk of having a concomitant prostate cancer. Again, it's sort of case by case. Many prostate cancers we diagnose are not necessarily clinically significant, so that prostate cancer may never bother them. In the setting of a Gleason 4+3 or unfavorable intermediate risk prostate cancer, that would be a clinically relevant and significant prostate cancer, in which case we would have to treat them both. And often what I'll do in that setting is tailor the radiation fields so that we can give radiation to the bladder while getting the chemotherapy, but then also give radiation to the prostate and add some sort of extra radiation towards the end, focus specifically on the prostate to also address their prostate cancer.
All right.
Alternative also is, of course, radical cystectomy, which would remove the prostate as well.
Right. All right. Thank you. And last question, in your experience, have you performed more radical cystectomies or TMT?
I would say that radical cystectomy is still probably the predominant therapy that a lot of these patients end up getting. In my case, my role was the radiation doctors in the trimodality setting, so that's what I'm most familiar with. But if you look at practice patterns nationally, radical cystectomy remains the dominant treatment for these patients.
All right. Thank you so much. Let's see. I've already mentioned about the website. We're on Facebook. We're on Twitter. And just to mention upcoming lectures, our next patient-centered care lecture on July 8th at noon, Cancer Care Delivery, Patient-Reported Outcomes with Dr. Angela Stover. And then on July 22nd, also at noon, Breast Cancer Management in North Carolina updates for 2020 with Dr. Emily Ray. So we look forward to having all of you for both of those. And please spread the word about those to others who may be interested in those. We have our learning portal with all kinds of different self-paced courses. We generally have 24 online at any given time, all free. We've just added Delivering Survivorship Care in North Carolina with Dr. Mayer and Head and Neck Cancer Management in North Carolina Updates 2020 with Dr. Sheff. So we hope you'll check out those and the other 22 that are available for credit there as well. All right, Dr. Royce, thank you so much. We really, really appreciate having you here today. This has been great, and we hope to have you back again sometime. Best wishes, and to our audience, thank you for being here, and we'll see you hopefully for our next lecture. Take care, everyone.
Thank you for having me.
Thank you.